Episode 27, a rugby tackle with shoulder symptoms. Welcome to Sports Medicine Case Studies, where I review published case studies, discuss key takeaways, and provide practice questions. The case today is a professional rugby player who was injured in a match following a tackle where he led with the right shoulder. So in other words, he's making the tackle and the opposing player impacted his body between his neck and right shoulder. Following the tackle, the patient presented to the sidelines with transient paralysis of the right upper limb associated with significant paresthesias. Within minutes of the accident, there was almost complete regression of his symptoms. But subsequently, he presented with persistent discomfort during training with associated weakness of the right upper limb, motivating a consultation 3 months after the initial tackle. The clinical evaluation at that point, and I'm going to quote the authors, demonstrated hypoesthesia of the shoulder stump, pain and muscle weakness on the external rotators of the right shoulder, and the notation of an irritative syndrome, which they describe as a pseudo-Tinel sign of the supraclavicular region, being compatible with incomplete C5 and C6 involvement. Initial x-rays of the cervical spine were normal. The differential diagnosis that I came up with: cervical radiculopathy, cervical stenosis, Parsonage-Turner syndrome, thoracic outlet syndrome. I want to recognize the authors, Dr. Delvaque et al. This article was published in Clinical Case Reports International in 2022, and the authors are out of the country of France. I'm Scott Hall, a primary care sports medicine physician, and I am studying for my sports medicine certification exam in 2026, and I hope you'll join me on the journey. This podcast is for educational purposes only. Okay, in terms of additional testing that the authors performed, they did dynamic bilateral positional Doppler ultrasound, EMGs of both upper extremities, and an MRI of the right brachial plexus. This evaluation was normal except for the brachial plexus MRI, which showed diffuse, and I quote, hyperfixation of the right brachial plexus. The authors provided a final diagnosis of slow recovery stinger lesion. The recommendation was made to initiate physical therapy with a prescription for low-dose pregabalin to treat irritative symptoms. 6 months after his trauma, the patient was seen in follow-up, and he reported a complete resolution of symptoms with a return to full strength with external rotation and normal sensation in his right upper extremity. The return to sport was performed at 6 months with the modification of placing an extra pad in the area of the right shoulder as a protection. Okay, a couple of key concepts. A stinger, also called a burner, is a transient traumatic neuropraxia of the cervical nerve roots or brachial plexus. The most commonly involved structures are the C5 and C6 nerve roots or the upper trunk of the brachial plexus. This injury is common in collision sports such as American football or rugby. Clinical presentation with athletes typically involves acute unilateral stinging pain, paresthesias, and occasionally motor weakness radiating from the shoulder down the arm. Importantly, there is typically no neck pain or limited cervical motion. Symptoms are strictly unilateral, which helps differentiate stingers from more serious cervical spine pathology. There are two primary mechanisms which are described in the literature as causative for stingers. First is a compression of the brachial plexus at the superior medial scapula, where the plexus is most superficial, and traction or lateral flexion and rotation of the neck away from the affected shoulder. Most stingers will resolve spontaneously, as described in the case report, within minutes, with athletes regaining full strength and range of motion. A recent study done with NFL players demonstrated that 76% of players diagnosed with stingers did not lose any competitive playing time. When time was lost, the mean was less than 5 days. However, symptoms can occasionally persist for up to 2 weeks or longer. The re-injury rate is substantial, approximately 37% per season in young rugby players, with a history of previous stingers being the strongest risk factor for recurrence. For return to play criteria, one of the references lists the following. So an athlete can return to play in the same game if 1, symptoms completely resolve within 5 minutes, 2, the neurologic examination is normal, 3, full cervical range of motion and strength are demonstrated, and 4, there are no bilateral symptoms. Athletes with recurrent stingers, persistent symptoms beyond 48 hours, bilateral symptoms, or any strength deficits require additional evaluation, which may include imaging and potentially electrodiagnostic studies before return to play. Okay, practice questions. Number 1, a 17-year-old high school football linebacker sustains a stinger during a tackle. Which of the following clinical features is most characteristic of this injury? A, bilateral upper extremity paresthesias with neck pain. B, unilateral burning pain and weakness in a C5-6 distribution without neck pain. C, bilateral lower extremity weakness. D, unilateral arm pain with limited cervical range of motion. E, bilateral upper extremity weakness lasting more than 15 minutes. Correct answer is B. Unilateral burning pain and weakness in a C5-C6 distribution without neck pain is pathognomonic of the presentation of most stingers. The injury involves a stretch or compression of the brachial plexus, which results in the unilateral symptoms. And key defining feature, the unilateral nature and absence of neck pain are critical distinguishing features. Okay, question 2. A 16-year-old running back sustains a stinger and is evaluated on the sideline 6 minutes after his injury. His symptoms have completely resolved. Which of the following is not a required criterion for same-day return to play? A, complete resolution of symptoms within 5 minutes. B, normal neurologic examination. C, full cervical range of motion and strength. D, normal cervical spine MRI. E, absence of bilateral symptoms. The correct answer is D. A normal cervical spine MRI is not required for same-day return to play after an uncomplicated single stinger with complete symptom resolution. Imaging is typically reserved for athletes with recurrent stingers, persistent symptoms beyond 2 weeks, or concerning features suggesting structural cervical pathology. Question 3. What are the 2 primary mechanisms of injury for stingers? A, hyperextension and axial loading. B, compression at Erb's point, also the superior medial aspect of the scapula, and traction from lateral neck flexion. C, a direct blow to the clavicle and shoulder dislocation. D, rotational injury and hyperflexion. E, axial compression and anterior translation. The correct answer is B, compression at the superior medial border of the scapula, along with lateral neck flexion. These are the 2 primary mechanisms. Compression occurs when the shoulder is forcibly depressed, compressing the brachial plexus at Erb's point, which is where the trunk passes between the clavicle and the first rib. Okay, question 4. An 18-year-old college linebacker has experienced 3 stingers over the past 6 weeks. A cervical spine MRI is obtained. Which of the following findings is most commonly associated with recurrent stingers? A, atlantoaxial instability. B, cervical disc herniation at C3. C, developmental cervical stenosis. D, odontoid fracture. And E, ligamentum flavum hypertrophy. The correct answer is C, developmental cervical stenosis. This is the most common underlying pathology in athletes with recurrent stingers. Stenosis of the spinal canal, whether congenital or acquired, predisposes athletes to both stingers and cervical cord neuropraxia by reducing the space available for neural elements. The Torg-Pavlov ratio, which is a ratio between the canal diameter and the vertebral body diameter, is used to assess the degree of stenosis, with values less than 0.8 considered abnormal. Okay, question 5. A 17-year-old football player sustained a stinger 10 days ago with persistent mild deltoid weakness. You are considering electrodiagnostic studies. What is the earliest time after injury that EMG findings of denervation would be expected to appear? A, 24 to 48 hours. B, 3 to 5 days. C, 7 to 10 days. D, 2 to 3 weeks. E, 6 to 8 weeks. The correct answer is D, 2 to 3 weeks. EMG findings of denervation with fibrillation potentials and positive sharp waves typically occur 2 to 3 weeks after nerve injury. This delay occurs because it takes time for denervated muscle fibers to develop the spontaneous electrical activity detected on EMG. And this is why generally early diagnostic testing is not useful for acute stinger management. Thank you.